Good evening and welcome to Partha YouTube channel. Subscribe to my channel to have more interesting videos about anesthesia pain. Today we are going to discuss about nasal intubation. We are going to discuss about nasal intubation. So, nasotracheal intubation involves passing an endotracheal tube through the navis, nasopharynx, trachea. So it is usually after GA. But it is an essential skill for anesthetist. Now we are passing it to the nares, nasopharynx, oropharynx, laryngopharynx, larynx, trachea. This is how it comes. Kuhn in 1902 did the first nasal intubation, and McGill and Rowbotham popularized after injuries from World War I. Now indications. Sometimes there is an intraoral surgery, complex intraoral procedures, mandibular reconstructive procedures, rigid laryngoscopy, dental surgeries, maxillofacial surgeries, orthodontic, ICU rarely, tube tolerance but resistance, preferably big. Now nasal tubes no, because sinusitis and pneumonia is more. Now going to this yellow dots. Now we can see here palatal, dental, oral, intraoral, retinognathic, mandibular surgeries are indications of nasotracheal intubation. Yes, this does not mean we should understand first. We should do an oral laryngoscopy and see any patient who is having a difficult oral laryngoscopy. You think that is also a case of difficult nasal intubation. What are the contraindications? Mid-phase instability, coagulopathy, basilar skull fractures, large nasal polyps, suspected foreign bodies, recent nasal surgeries, suspected epiglottitis, upper neck hematoma, all these things, frequent epistaxis, big adenoids. Big adenoids is one of the common relative contraindications, what we see in practice. So if the stability is not there, and there is a coagulopathy, and there is basilar skull fracture, nasal bone already surgery done, something like that, large polyps, there is no entry at all. Suspected nasal foreign bodies, no. Elimination of laryngoscope is very important, and preferably two, because as soon as you put the laryngoscope, you have introduced to the nose and you will see only blood. So ready with suction, one or two group laryngoscopes. Sometimes people soak in normal saline, jelly and xylometazoline drops if there is no gross contraindications. Put it 20 minutes earlier, otherwise it will not act. Put it at least 5-10 minutes earlier and use a jelly and a good laryngoscope. Ask the patient which side is patent. That is a very easy question. Sometimes people, original teaching is the anterior where it is patent, posterior it is not patent. So sometimes people choose where there is an anteriorly block. I always choose the right side preferably, well facing the narix. I think the passage through the cords is easier. Now if you go to anatomy, this is the inferior turbinate, middle turbinate, superior turbinate. Now the nasal vestibule is there. We are passing the tube like this, and this is the skull base, okay, palate. And this has to come through here to here, okay. Now you see this is the inferior turbinate and middle turbinate. Correct size tube is 1 millimeter smaller than oral tube. That's very simple formula. Calculate the oral formula, give 1 millimeter. If the oral tube I think is 6, then you put 5. If the oral tube is think is 8, then you put 7. That is simple formula. Cuff check and gel and xylocaine drops. Rhinoscopy prior the day before. Blow air and ask the patient. Now nasal look before you leave. See here. I always put simple normal laryngoscope prior to nasal tube insert.
The tube here. Before you put the tube here, always do a laryngoscopy and see your laryngomach whether you can able to intubate or not.
There is no blood, we can do suction, everything is fine. Then you start doing your nasotracheal intubation. Previously what we had is disposable cup. Previously, nasal tubes are separate and oral tubes are separated rubber. You can see the nasal tube is like this, more curved, and the bevel is like this. This is the nasal tube. Now, if you take an oral tube here,
Now this was the
this is the
original
nasal tube.
nasal tube made of red rubber.
The
This
curvature is more,
curvature, the
but
radius
the
of
bevel is
curvature, you can see the curvature is more and the
now you
radius
can
of
see the
curvature is
oral
less in this. And you can see nasal 6.5. It's usually all are uncuffed.
smaller
You can
tube
see
is
the
like
bevel
now.
very oval
And
and
so now
very
this is oral
lengthy.
tube.
This is about the
This is
nasal
nasal
tube.
tube. I
Now
am
when
picking
you
up
take
the
the
oral tube.
oral tube,
Now you see
this is
the
more of
curvature
a,
is more
you
flat.
see the curvature
The
is
bevel
not
is
that
different.
much. You can see it is written here oral.
That is oral tube.
You can see here written oral and see the bevel. The bevel and the difference
Okay,
between the bevel is very clear now. This
that
is
is the
what is
nasal
the
tube,
original
oral
nasal
tube.
and
Previously,
original
now we
oral
have got
tubes made by Roche.
disposable
But
cup
this has
or
been condemned that we are using only.
Preoxygenate with intubating position, GA with relaxants, dilation with nasopharyngeal airway people may sometimes put. Insert the tube vertical, that is very important because the path is vertical here, just vertical and go in. So if you want to go lightly, go 2 millimeters, go like this and then go straight. The tube enters the oropharynx, overcomes the small resistance, do a laryngoscopy, direct the tube. An assistant also can push the tube. Check and fix. Smaller McGill's forceps. Sometimes neutral position facilitates nasotracheal intubation than your traditional sniffing position. Now I will show you how the bevel and turning helps. Now I am putting the nasal
Bevel
tube.
like this clearly. I am just introducing into the right nostril,
Now I am putting
just
the nasal
vertically
tube through the right
down.
nares. Now it
Now
comes to the, now
see here,
I can see that it's coming to
here
the
this turbinate is
oropharynx,
seen. If I
nasopharynx and
want to rotate
oropharynx.
the tube like
Then I
this,
am
the
pushing the,
turbinate is going to get lifted up, which I don't want. If I want to rotate, you
now you see
rotate
the
like
turn,
this
what happens here.
and slid like this.
Beautifully it is coming down.
Okay?
This is how that one is the bevel turn when the tube turns, overcomes and comes to the front, not to the back. This is how the turning of the tube is very important in pushing the tube anteriorly if it goes posterior. Tube width is 29 centimeters while depth is 26 centimeters. Use the depth mark. The chula formula is there, 9 plus body height by 10 centimeters. Adult male 7.5, female 7. Or so-called depth is there always, but we have got always the marker. Fix the marker properly you are in. Though these are all called lighted stillets, we can use these lighted stillets and push the nasotracheal tube in. Now, fiber optic nasal intubation and retrograde are separate topics. This is retrograde intubation I am doing here, and I am getting the epidural catheter. I am going to pass like this. This is a retrograde is a separate topic. The path is not always smooth like this. Now you see when insertion, I have already told, inferior turbinate, middle turbinate. There are two pathways here. The tube can go here or the tube can go through this. The middle turbinate is attached to the base of the cranium. So CS of rhinoria and epistaxis dangerous. Preformed tubes may go upper. So routine tubes may go lower. So these may be two paths. The tube overcomes the initial turbinate resistance and hits the pharyngeal wall. Now a stillet can be used to get the curve here. Now what happens is now you have it is hitting now. Okay. Now you use a stillet and get the curve in here down. That is what I told, how to push. Sometimes tube rotation may get it anterior. Sometimes slightly inflate the tube. If you inflate the tube, now you see it is coming anterior. Sitting positions may be used for fiber optic nasal intubations. Suction is so important. Sometimes we need to suck the adenoids also. We push in the adenoids is full of blood, so As soon as you push the tube full of blood here, you do a laryngoscopy, we will not see anything. So good suction is essential. Now you can see here.
Okay, sir. Now I am introducing
I am
the tube
inserting the
vertically like this, and the initial resistance
endotracheal
which
tube
I
in the
am now
nasal
past
cavity.
is
Now it is
turbinate.
coming here.
And after that, I am going like this. You see, I am hitting the
Yes,
nasopharynx.
it is
This
inserting.
nasopharynx comes at around 8 to 9 centimeters here. You
Now
can
we
see
know.
here 8 to 9 centimeters. So any resistance after 4 or 5 centimeters
Yes,
is going to be the nasopharynx. Then you can slit it like
yes,
this, and
it is
then the
going,
tube is going
going,
like
going,
this.
going,
Can you see
going.
the tube going like this? It hits in the
It's here.
anterior position, means
Now what I
if it
do?
hits the anterior position, you can just
Yes.
rotate it
Now I
like
rotate
this and
here
slid it like
and then
this. It's
take.
going like this very
Okay.
nicely. Yeah.
So this is a simple technique. The natural tendency of the nasal tube is to go anterior after it crosses the oropharynx. Then if it hitches here, then you have to flex the neck. If you flex the neck, the tube will slid in. Keep your other hand on the cricoid cartilage to pass palpate and assist. Sometimes you need a Shellick's manual to get at the tube here. This is the esophagus, which is posterior. Now it is going anterior to the larynx. Just flex. Just flex the neck. An orotracheal tube usually slides posterior. Sir esophagus. A nasotracheal tube usually slides anterior. This is very simple. Sometimes if you do relax the laryngoscope, it will correct the anterior hitch. Now you are not pushing the laryngoscope too much, just relax your laryngoscope. The tube will automatically correct the anterior hitch and go into the larynx. This hitch is corrected and it will go to the larynx. Problems in the tip of the larynx. Now the larynx has to, tip of the larynx has to, endotracheal tube has to go here. Now it is hitting here. It is likely the tube got directed in the anterior of the larynx. Withdrawing slightly and flexing the neck. That's what I do. You just flex the neck. Other techniques I have rotated. Sometimes you can pass the bougie to the tube. You can ask the still left to go in. Turning the tracheal tube bevel faces up may avoid impinging the tip in beside the right vocal cord. Now you can see, just turn it so that it doesn't hitch the right vocal cord. There is something called Wendel's tube as a pathfinder. You can insert it. So there is a decreased epistaxis, nasal pain, and tube contamination. An hemispherical bevel reduces nasal morbidity. This bevel is not very good. So hemispherical bevel is better. With previous points have gone with left facing bevel here. You can see here the bevel, how it is, the bevel is faced. Hemispherical bevel. A dual bougie. Now there is a dual laryngoscopy. Do a oral tube. Okay. Now, and there is a bougie inside. Okay. Through the nose, put another tube with the bougie and progress the nasal bougie into the trachea, remove oral tube and thread through the nasal tube. Okay. Because then we can remove the oral bougie. Difficult again. Oral bougie and tube. Then do through the nasal bougie alone. Then thread the nasal tube. Then take out the oral tube alone. If the nasal tube is in properly, take out the oral bougie, nasal bougie. Securing the tube is easier, very important. Oral, it will not move here and there. It is very easy to secure. Nasal roots, the tube will be occluded by biting. We cannot bite a nasal tube. Nasal intubation may less cause cell cervical movement than oral intubation. But it is a difficult technique. Smaller tube, and in emergencies and hypoxia, we cannot do. Sinusitis, danger. So epistaxis, avulsion of turbinate, obstruction of endotracheal lumen. See, for example, a big adenoid chunk is there in that tube. Okay. As soon as you put the tube, you cannot ventilate because the chunk of adenoid in the tip of the endotracheal tube. So bevel on the side of the ears, we can hitch the carbonates or injure the kissel backs. Focus the tube towards the floor. For example, you think the hole is like this. You insert the tube, just tip here, and then go vertically. This is how a tube should be inserted. Because the inside hole is directly down. It is not like this. Nasal passage is smooth and less epistaxis. Epistaxis was most likely to occur was transit of the tubes. Age, gender, obesity, smoking, to repeated attempts are not significantly associated. There are few cases of middle turbinate avulsion. Rarely we need to give GA for oral tube and put a turbinectomy done and then start your original procedures. Yes, it's an intubation. Pulse and BP are going to rise. Sympathetic stimulation is going to that, plus laryngoscopy and intubation. Other side effects may be vagal stimulation, spasm, vocal cord damage, bacteremia from introduction of nasal flora, streptococci and coryn bacteria. Intracranial placement of the nasal tracheal tube or facial fracture. Retropharyngeal dissection can go up or down everywhere. Okay? Sometimes I have encountered this cuff rupture. You don't pick up them with Megill cuff. Perforation of pyriform fossa can occur. Inadvertent cranial placement. Sinusitis. So many complications. Fracture of the turbinate. CS of rhinorrhea. Middle turbinate is gone. Post-extubation, laryngeal problems are less with nasal intubation. Leave alone other morbidity. The epistaxis, all these things. Laryngeal problems are less. Now, very important what I want to tell you. Focus here. Whenever you put a nasotracheal tube, also keep the inflating channel and the tube in one hand. Not only the tube, leave alone this, that should not be done, because if the tube goes here and if our inflating channel goes here, then we cannot extubate. Now we have to cut everything and then start extubating. So both should go the same path. This was published by us. During introduction, hold the tube and inflating channel together. Yes, both should follow the same path. Now, if it goes, there are already two pathways I told. Inferior turbinate, middle turbinate. Above the middle turbinate, inflating channel goes. Below this middle turbinate, tube goes. Yes, very difficult to extubate. If the tube is not following the path, put the oral tube and ventilate. Right time, negotiate and put the nasal tube. Don't be hurry up. Put the oral tube. If you are following hypoxia, nothing. Put an oral tube, start ventilate. Remember, in fiber optic scope of air, the introduction has also to face resistances. Fiber optic is again fantastic. Nasal tube. Yes, it is to reach the turbinate. The tube has to reach the turbinate. The tube has to reach the nasal pharynx. Everything remains. So all these resistance are there even in fiber optic aided. Dental surgeons can suture wires are in the tubes. So many complications. Epistaxis, bleeding, all these things, trauma, intervenate, everything is there. But I know I'll tell you what complications I have done. Insert of the Rice tube when the plan is to put prefer a rhinoscope. Prefer to insert endotracheal tube, then try Rice tube later. All centers. Blind nasal is a separate topic. I am not going to do this. Complications, failed intubation, epistaxis. I have done palatal tear. I have done retropharyngeal, partial turbinate tear, retinoid injury, but recovered, cuff damage. So many things I have done. Cuff, sometimes it's difficult to pick up the tip. So sometimes we just, with your forceps, Megill's, you have to pick up the cuff and put in, yes, damaged cuff. We know the indications. Oral, mandibular, orthognathic, surgeries. We know the equipment. Yes, we know the technique. First do a laryngoscopy, then insert. Sometimes we will insert an NPA and then insert to create a pathway. So many tips are there, how to rotate that tube, how to partially inflate and get it, how to flex the neck and get it up, down, so many things. Complications are there, so many I have described, even I have made. Understand the science anatomy. Naturally, the technique will look like an art, but it is science which is behind the art. Practice it as a science. Thank you very much. Visit me at painfreepartha.com and my YouTube channel, Pain Free Partha. Thank you.